can't hear me, just holler. I'm going to try to speak loudly. And please feel free to ask questions all the way through. So if you have a question, just go ahead and stop me and we'll ask questions. Okay. Today we're going to be talking about breast, cervical, and colorectal, but we're going to predominantly be talking about breast. So to start off with, I'm going to talk a little bit about cancer-related checkups. So the idea of a cancer-related checkup is to have conversations with your physician about cancer and cancer screening and when those things should be done. So one of the things that I always like to point out is the importance of talking to your doctor about things that might be in your family history, right? So when somebody might have had cancer in your life that you are connected to, how old they are, when they were diagnosed, things like that. So I always use myself as an example, so it's important to know something like this. My mom was diagnosed at 69 with ovarian cancer, right? And giving that information to your doctor, and then from there, they may adjust your screening tests or when they want you to get things done. Second is being proactive. So be sure to ask questions, right? Specifically about cancer screening. So we're going to talk about cancer screening. But if your doctor says you don't need that cancer screening, ask them why. You might be surprised at the reason. And we'll talk a little bit more about that too. And then lastly, it's reporting to your doctor when something seems to be wrong. You show your body the best. So when something changes, that's something to let your doctor know about. Alright, so these are some questions. And just so you know, I have copies of this presentation that you can all have. So if you want copies of that, I will definitely give that to you. So some questions that you might want to ask about a test or procedure. Something like, why do I need that test? What can I expect when I go to get that test? Right? How long will it take? Right? Is it necessary? Or especially when your results are done, what do those results mean? Okay? So be sure to take questions to your doctor. And the best way to do that is to write them down. Right? You're going in to see your doctor, write those questions down, take them with them, and you can just give them to them and get those answers to your questions. So I'd say kind of like, this isn't new for your doctor, but it might be new for you. You might not have ever experienced that. So ask questions, ask questions, ask questions. So before we get started, let me talk a little bit about a couple different definitions so that we understand what I'm going to be talking about. So the first one is a risk factor. And a risk factor means that it's something that increases a person's chance of getting a disease. But just because they have that risk factor doesn't mean they will get it. And just because they don't have that risk factor doesn't mean that they won't get it. Okay? So some risk factors can be controlled and some cannot. So we can choose not to smoke, we can eat healthy, we can be physically active. Those are things we can control. But then there's other things that we can't control. We can't help that we're getting older, right? We can't help what our race, our gender, our ethnicity is. Those things we can't change. Maybe what falls in our family history. We'll talk more about those for each cancer. The next piece is a screening test. And a screening test is a test where we're testing to see if we can find some type of disease or something going on before you have any symptoms, right? And we do it for cancer, but we also do it for other things. So our blood pressure and our sugar tests, all those things, we're looking for possible problems before you're showing any symptoms, before it gets too far. And the last piece is a self-exam. And a self-exam is when we inspect our body for changes. And self-exams are somewhat recommended. So some of the big organizations don't necessarily recommend self-exams anymore because that doesn't actually decrease the mortality rate. But we all know when we go to our doctor, they a lot of times ask us to do your self-exams, right? So we'll talk a little bit more about them. But the idea really is to notice if there's anything different and then report that to your doctor. start with breast cancer. And I'm a bit of a statistic buff, so I like statistics, so I have a tendency to start with those. Breast cancer is the most common cancer in women, except for skin. Okay. Counts for 1 of 3 all new female cancers each year. We have a 1 in 8 chance of getting breast cancer, and a 1 in 40th chance of dying of breast cancer. And Black women have the highest death rate from breast cancer. We're going to talk a little bit about that as we move forward. It's like, how are we doing locally, right? So I just also did this presentation in Atlantic County, and the one thing in Cape May County is your numbers are just generally smaller in Cape May County, so sometimes it's hard to get statistics in the same way. But overall, in Cape May County, breast cancer rates are higher than the state rate. Okay. Black women are higher than the state as well. Hispanic women are much higher. However, I think that really has to do with the small numbers in the county. And Asian women are suppressed, so there's so few that it's suppressed altogether. And then you see the same kind of thing with the mortality rate. Overall, the mortality rate for breast cancer in Cape May County is higher than the state, but Black women, Hispanic women, and Asian women's mortality rates aren't available, and that has to do with the numbers of people in the county. However, what we see in Atlantic County is a little different. In Atlantic County, our breast cancer rate is actually lower, and then our mortality rate is actually higher, especially for Black women. So that's why it's a concern. So you're like, well, how many people is that, right? That's hard to tell, right? So not quite 100,000 people in Atlantic County. So out of that, in a 5-year period, 677 women were diagnosed with breast cancer. And in that same time period, 104 deaths occurred. 98 of them were white women. So that means it was less than, what, it's like, that's like 6. Yeah, about 6. Alright, so I gave a definition about risk factors, right? So, number 1 risk factor for breast cancer is being a woman, right? So that's our number 1. A lot of times people think it's family history, and that is important, but just the fact that you're a woman is the number 1. Some other ones are also getting older, it's by age, and then also inheriting certain genetic factors, such as BRCA gene. And have people heard of the BRCA gene? Okay. So basically, it's a genetic component that increases a woman's risk to get breast cancer. So 7 in 10 women with a BRCA gene will be diagnosed with breast cancer before they're 80. Okay. More likely in most breasts, and they have a higher risk of ovarian cancer as well. So in one of my other presentations, somebody asked me, well, how do I know if I have the BRCA gene? Right? That was a question that came out. And so that will be something that often will get tested if you have another family member who maybe had breast cancer, especially if they're on the younger side, right? Since breast and ovarian are connected, I was BRCA tested because my mom had ovarian cancer, so that test was offered to me. If you had say your mom was diagnosed under 50, they always do BRCA testing on women who are under 50 for breast cancer when they're diagnosed. And they have even started to go older than that now. So there's definitely different ways that kind of comes where people know about that. Okay. Personal history, right? Race. White women are more likely to get it, but Black women have higher rates of mortality. Right? And like I said, we're going to talk a little bit about that. And then some of the other ones, they move lower. And of course, we have the lifestyle-related ones, taking good care of ourselves. Alcohol increases our risk of breast cancer. When I looked that up, it said it's clearly linked with 2 to 3 drinks a day, a 20% increase. It surprised me when I looked that up. Right? Obesity, not being physically active, things like that. All right. So breast density is one of those things so I wanted to talk a little bit about breast density. Basically, dense breasts are breasts that have less fatty tissue. So we have all the stuff that's supposed to be in our breasts, like our milk ducts and things like that, and then we also have fatty tissue. And so it has to do with the ratio between those. So this picture with this one is a breast that has more fatty tissue. And you can see how well you can kind of see into that breast, right? And then this breast right here has more of that white component, right? So that breast is a dense breast. Now, when you look for a tumor in a breast, it's also white. So you can see why it's harder to find a breast cancer in a breast that's dense. Okay. So I think like pictures are really great. They kind of let you know, and you can see exactly what we're talking about here. Okay. So women with dense breasts have a higher risk of getting breast cancer, and they're harder to detect. Okay. And generally, women with dense breasts are younger women, pregnant or breastfeeding women, women who are taking hormone replacements, or have a lower body weight. And that breast density is reported on your mammogram results. So if you have, and this is where those cancer-related checkups conversations fall, if you're a woman who has denser breasts, that's a conversation with your doctor to see if there's additional testing that you might want to have done besides just your annual mammogram. Does that make sense?
Mm-hmm.
Any questions about that?
Mm.
Yeah, go ahead.
All right, so they bumped it up to, what is it, it's a different test now than they used to give years ago, 3Ds or something?
3D. Yeah, we're going to talk about screening tests in just a minute. So we're going to get to that. Yeah.
I could just make a
You
comment,
go ahead,
since
answer.
I get all the reports. If you do have dense breast, the radiologist will suggest on your results that you get further screening, and they'll contact us for a prescription for the further testing. So that's very common. I would say over half of the mammograms that we have done, screening mammograms, come back for more studies, either a diagnostic mammogram or an ultrasound in addition.
I have a question. You were saying that, when you talked about the breast cancer, they're finding out men are getting it also.
Yes, and so men also can get breast cancer, and especially if they also have that BRCA gene, it's just not as common. The
Right.
risk is a lot lower.
And when you test positive, because I'm a breast cancer survivor, so I did test positive for the BRCA gene, and they gave me a total hysterectomy. I have no daughters, but I have 3 sons, and I'm gonna suggest that, they get some type of testing, because I do have 3 grown sons now, and they need to be tested, because today, basically, you can get certain tests, and they can pinpoint to tell you, what's there, how to prevent it, because things are more modernized from when I had breast cancer.
So that's exactly family history, right? We talked about that, knowing family history, what type of family history runs in there for your boys to know, and your boys might have granddaughters someday, and
I do.
things like
I
that,
have
right?
3
Three
granddaughters.
granddaughters, exactly. Yeah. All right, so screening, we talked about screening, so we wanna do screening beforehand. So for the most part, through our programs, we recommend that when we get a clinical breast exam, right, we go to our GYN every year, and part of that GYN appointment is a clinical breast exam. Mammograms at age 40 and over annually, and women with a greater risk, that's 20% or higher, talk to the doctor about additional screening options. So for example, I use myself a lot, and that's where I share too much of my personal history, right? So my mom had ovarian cancer, I'm considered higher risk for breast. I get a mammogram, 6 months later, I get a breast MRI. 6 months later, I get a mammogram, 6 months later, I get a breast MRI. So it's just, sometimes there's different screenings for your family with that BRCA gene in there. The screening recommendations may be different.
I got a question. How are you getting all these tests? Not being smart, because, sometimes they give me the business, and the doctor has to keep writing, and she'll say, don't you do it, I'll do it.
Right.
you know,
Yes,
so.
she has
yeah.
to challenge them for.
Yeah, yes,
For that
yes,
period
yes,
or something like
yes,
that. Yeah.
yes,
Yeah.
yes.
So I mean, sometimes our insurance companies
Yeah,
pump it.
yeah.
Yeah, sometimes they do. I haven't had too much trouble with the mammography. You know what I mean?
No, you don't, but go higher, here it comes.
Okay.
And as you say, just keep fighting and she'll say, I'll handle it. She says, I'll get it done, don't you worry about it.
Yeah. It sounds like you have a great doctor there.
Yeah, I had a good team.
So I put two different recommendations up here. So definitely from our program standpoint, this is what we kind of recommend. To keep it simple, right? You're going to your doctor every year, you're having conversations with your doctor every year, and talking about what type of screening you should get for your risk, okay? But I put this up here because American Cancer Society has recommendations out there, and American Cancer Society is also part of the U.S. Preventive Task Force, which is what essentially gives us our direction as far as when people should be screened. And the U.S. Task Force just updated this in April. So this is brand new. So I anticipate the American Cancer Society will probably update as well soon. And American Cancer Society is part of the U.S. Task Force group that makes these decisions. But the big piece that they're talking about is you see a shift from where they were kind of expanding when people should start their mammograms in that 40 to 50, taking that back to the 40s. So anybody who's been around for a while knew it was 40, 40, 40, and they were like, oh, maybe 50. And then women were really upset about that, and it went back to, you can get one in your 40s or 50s. And it's shifting back again to women between ages 40 and 74 should be screened. So it's gone back to that 40 pretty solidly. Then they talk about, specifically, we have our average risk, but specific groups that they believe should be researched more. And that's women with dense breasts, black women, because they're passing more for breast cancer, and women over 75, and what those recommendations should look like. Okay. So, that's kind of the change. And so I have this cute little infograph, I love this infograph, right? Specifically that they put out, which is really talking about some of those things that we talked about already, and some of the things we're gonna talk about in a minute, but that it's common, we have higher risks for black women.
I have a question. Do we know why there's a higher risk
We're
with?
gonna talk about that in just a
Okay.
minute, yeah.
Okay.
Higher risk for black women. Everyone should start screening at 40, and if we did that, we could save 19% more lives could be saved by starting to screen all women at age 40.
Wow.
And then they have these specific scientific research pieces that they believe we need to look into more. Okay? So yes, so why do we have a gap between black women and white women? And it's complex. And, you know, we used to just think it was because they're not getting screenings or they're not having access to health care, right? And that is a component, but it's not the only reason, okay? So first, black women are statistically more likely to have diabetes, heart disease, and obesity, and less likely to breastfeed, and all of those things are risk factors for breast cancer. Secondly, they're more likely to have inadequate health insurance or access to health care facilities. And that affects screening, follow-up, and completion of therapy, right? So finishing that cancer treatment. They're more likely to get aggressive subtypes of breast cancer, such as triple negative and inflammatory breast cancer. And I'm gonna talk about inflammatory breast cancer in a minute. And they're more likely to be diagnosed at younger ages with more aggressive advanced stages. Okay. And then black women's tumors may respond differently to endocrine therapies and more frequently are resistant to therapy, right? So they're more resistant to those therapies, and that's why it's important to have more black women part of our clinical trials for breast cancer. So we can make sure that we're getting the right treatments for the right types of cancer. But sometimes we're getting more aggressive types of cancer as well. So it's a multiple aspect of that. But was interesting is I was just writing a grant recently and I looked up mammogram numbers, and in New Jersey, black women actually have higher percentages of mammograms than the overall population, right? So there's just more to it than what we think, or what we've always thought it was before, I think. But- Which is why, right here, from the US Preventive Task Force, they're saying we need to do more research on black women and why we have this gap.
I have a question.
Sure.
How do black women of color get into the programs for research?
That's a good question, 'cause somebody asked me that before too.
That's the issue.
Yeah, yeah, I think, like, I know when we do cancer treatment in our cancer center specifically, every patient who comes through is looked for treatment, but that's, like, as we do their case, right, we look to see if there's a clinical trial that's appropriate for that particular case,
Oh, okay.
right? So, but that is at this treatment stage.
Right, but
Right,
you're,
so how do we get into those
Right.
trials prior to treatment, like earlier on? That I'm not as sure about.
now, where you do your cancer treatment screenings and all of that, does everybody follow the same guidelines?
For screening,
Yes.
I mean, if you look like that last slide, I think it's confusing, like when people should be screened, right?
Right.
So most doctors are screening for mammograms every year, but even the recommendation doesn't necessarily say that. It says you can do it every other year
Right.
or, right? And then sometimes doctors or sometimes people stop screening at a certain point, right? So it kind of can vary.
Right, and for any clinical trial, whether it's breast cancer or whatever, just my personal, I don't think people of color know where to go.
Right.
You know, the doctors don't tell you that, you know, you could be a candidate for this or that. You know, maybe it starts at that level, you know, getting the doctor to tell, you know, women, men, or whoever, you know, I think you need to be in a program where we can start monitoring you a little different. Maybe that's where it starts.
Where are the location of these programs too? Are they in suburban areas, or are they in,
Right. So a lot of times your
city
clinical
areas,
trials are
urban
in big
areas.
city hospitals and things like that, like you see that a lot when you're looking at clinical trials, it's connected
But
to
don't
the
they
university
provide-
hospitals and things like that, yeah.
What they
So
provide.
sometimes that's not as easy for people to travel
Right,
to
right.
and all those kind of things, absolutely.
What's
Some clinical trials though will pay for people to travel to get
Travel,
there and things like that, so.
And Cape May County doesn't have any, do they?
Well, Cooper's coming, so
Right,
once
that's what
Cooper gets here.
When?
Yeah.
Well, it was May first, now it's June first, but we're gonna get the Anderson Cancer Center from Cooper here at Cape Regional.
So that'll-
Okay, so
then
we're gonna
we'll
see a
absolutely-
change.
Yes, we hope we're
Absolutely.
gonna see a change.
Yeah,
Looking forward to that.
Okay, good to know that.
So, but the clinical trials, yes, the doctor that diagnoses you should be the one that's helping to look for some trials for you if you have an unusual kind of cancer that requires a different kind of treatment protocol than other ones. And, all the major teaching centers, they do clinical trials all the time, it's just your doctor has to.
Penn is affiliated with Shore Medical Center, Cancer Center, and they offer our patients clinical trials with transportation and housing.
That's Atlantic County.
Yeah.
You can still go there even if you live in Cape County.
Yeah. But it'll just be a little more, we'll have a little more now with two places that have a
Okay,
teaching hospital.
Right, all that information is good, but I think a lot of people have problems with transportation.
So the
There's
hope
programs
is
set
that
up to
once you have like Cooper is essentially gonna be on a satellite of the other Cooper.
Yeah.
Right? I think the hope is that once you have that, is that you won't have to go to
Camden.
Camden
Right,
to do
I
that. You'll be able
understand
to,
that.
so
Yep.
when they
Yeah.
take those blood samples they need, or
Mhm.
maybe the testing or whatever, someone from here will be able to do that.
Right.
And that's what really what all these, affiliations that hospitals are doing, like we're affiliated with Penn, Cooper's affiliated with MD Anderson, like as those affiliations connect, it helps especially for that, because a
Right,
smaller community hospital really can't do
Absolutely,
clinical
that's
trials
right.
in the masses because they don't have enough of numbers to do those kind of trials, and so they connect to those bigger university hospitals that can provide that service.
I know, like in North Jersey, I've seen like mobiles that come to the site, so that's what they need to bring, like like an area here like Whitesboro or any area, because like she said, people don't want to travel far. Is that some they can because they travel to do anything else. It's just they don't want to. So you really need to make it convenient when it comes to dealing with medicine or medical or something on that level. It needs to be convenient. So they have to, you know, just like when we had the COVID shots, we made it convenient. We were doing shots here. They were doing shots everywhere. So it's something like it's a pop-up clinic. Do a pop-up clinic at various sites to make it easy. So there's no excuse for you not to get there and have it different locations, different times. But you said Cooper's coming, so hopefully they'll look into something.
Yeah, and
Like
another
that.
group that does things from time to time is American Cancer Society, and they don't necessarily expect you to travel. So I'm in an American Cancer Society clinical trial right now, and all I do every couple of years is fill out their survey, right? And so they did that years, like they're not focused on smoking specifically with the one that I'm in, but years ago they did the smoking, and that's how they connected smoking to cancer and things like that. So some of them don't necessarily require you to be, like this one didn't require me to be blood sampled and like all that kind of stuff. Like it was all done online. So sometimes they have things like that too.
And I like what you said, because I knew someone stage 4 cancer and they were going to MD Anderson. They were struggling to get there, and it
so
was
hard
so
to drive.
heart-wrenching. So, some kind of way, I was sharing with the family, you know, talk to the social worker. There has to be a way where maybe he could get treatment here, but then that's a whole new ball game too, when you transfer from up there, come down this end. But they said they're gonna start seeking treatment closer to home, because they were struggling to get there. So I like that MD Anderson is coming here, and we're going, like you said, and I just read that, you won't have to travel.
We see
And
that.
that's a blessing.
I see that in the cancer center when I talk to patients, for people who were traveling to Penn for a while and they switched over to
it's a lot.
Shore, and they're just like, it's so much easier. Or they'll just, even if you're getting your main consults at the big city and you only have to go from time to time, but then you get your radiation locally, right? They have the same technology and the same machines. Like Cape Radiology, right? I mean, Cape Regional right now has the same
They do.
radiation technology that you'll get in the big city.
Oh wow, that's good.
Absolutely. All right, so I said we'd talk a little bit about inflammatory, right? So first off, with inflammatory, is I want to point out that it's very rare, okay? So don't get panicked. 1 to 5% of all breast cancers are inflammatory breast cancer. In the 18 years I've been at the hospital, I've seen one. Okay, so they're pretty rare. Generally, it doesn't start with a lump, and it may not show up on a mammogram. It tends to happen in younger women, and it tends to develop in black women more often. So, it's more common in women who are overweight or obese, it's more aggressive, and it spreads quicker, and it's generally found in a more advanced stage. Okay, so you're like, all right, so what's it look like, right? So, it's swells. So it's when one of the breasts swells, right? A lot of times it has redness on 1/3 of the breast. It may thicken or look like an orange peel, right? So the skin looks like that orange texture. It's possible the nipple will invert, and one breast is usually larger, warmer, heavier, can be tender or painful. So I tried to find a photo, and if you Google inflammatory breast cancer, there's tons of photos out there, but they're all copywritten, so I couldn't steal one of those. But basically, the one breast it will get larger, and it'll look different than the other breast, right? Now, sometimes what happens is women get mastitis, or they get a clogged milk duct, right? Or an infection in their breast, and it can look a lot like that, okay? So you find this in your breast, and you go to the doctor, they give you an antibiotic, because they think you have an infection in your breast. That's an appropriate treatment, but if that antibiotic doesn't work, it might go back and they might give you another antibiotic, and at the same time, you're like, I want to be tested for breast cancer, right? That's really the big thing, okay? So it's just recognizing that difference. Any questions about that? If you Google it, it'll pop right up, you can see see what the difference is, but basically, it's, you're gonna see a difference. Okay. So that kind of takes us into those self-exams, right? What are we doing with self-exams? So basically, the idea of a self-exam is to examine your breast and notice any kind of change so that you can alert your doctor, right? So first off, I always like to tell people your breast tissue is not just your boobs, right? It's all in this area, through the center and around. So there's more to it than just the front, okay? You're gonna check visually in the mirror, and you're gonna look for a lot of those things we just talked about, which is one bigger than the other? Is one swollen? Is there any discharge? Do we have any of that dimpling or that orange peel skin looking type thing, right? Scaliness, redness, puckering or inverted nipples, things like that. So we're just looking to see if there's any visual difference. Okay. Then the second part of that comes with actually feeling your breast. So you can do it in two different ways, right? So one way that's really well is being in the shower. You have the soapy fingers and your fingers slide easier across the skin. And another way is to lay down, right? Because we all know once we lay down, our boobs do this, right? So you can feel a different part of the breast. All right, so you go into a circular motion around the breast until you get all the way through to the nipple, okay? It does take a little pressure, so sometimes it's not like this. You need to push a little bit so you can feel, all right? And then you can do those on both ways. If you notice anything different, then that's something to take to your doctor and ask. Now, some women have like lumpy, bumpy breasts, like not everybody's women. So it's by doing those that you can take that to your doctor and figure out what's normal for you so that you're feeling for that. So I brought boobs with me, right? So that, I brought boobs with me. So you can feel the boob, the breast, and there's lumps in here. So it'll give you an opportunity to feel how you kind of have to put some pressure on it to feel the breast. So I will pass those around and you can do that at home. Start one on each side.
Do you have the key now?
I do have the key.
They're tough to find.
Yeah, sometimes they're tough to find, and I do have a key. That's in the other box.
All right, I'm gonna, if I duck,
This one, does this have it? This one doesn't.
They both have pumps. There's some tiny ones that you won't feel, but there's 1, 2, 3, 4 lumps in there at different
In
sizes.
each breast.
In each breast. Different sizes. Smaller and bigger lumps inside.
Miss Lee, you ain't feel none? Yeah.
So I do this every time. I also go past this little tool that's in your bag, right? So this little tool in your bag, it tells you, you can take a look at this, that's your user, but it tells you each bead in the bag has to do with a different size lump that can be found in the breast. And then it tells you what the bead stands for. So the little tiny bead that's in here, which I can't even see at the moment, that's mine. I think I lost the little tiny bead. There's a little tiny bead inside the bag that shows what a woman who gets their mammogram every year to 2 years, what a mammogram will like. It's a little tiny bead in the bag.
That's nice.
Okay? And then it explains what each lump is. And then like this great big one right here is a woman who rarely performs her self-breast exam or gets mammograms. Right? So it just kind of shows the different stages of when we can find breast cancer and a lump in somebody's breast.
I have a question.
Sure.
Do y'all teach this in school? They let you in school? It's nice.
I have taught it in schools, so schools are charged to teach information about breast cancer,
Oh, they need you guys.
and they're also charged to teach information about testicular cancer
Really?
for boys and girls, because testicular cancer is a younger cancer generally.
Now, is that a health class no more?
They're supposed to. It is actually legally on the books in New Jersey.
I forget, but they need to look back, they need to
What
put
about
it
the
in
test they
school.
give the young people, the shot, what is that?
HPV? Yeah, we're gonna talk about that too.
Oh, God.
Is that mandatory?
It's an individual choice.
It's
isn't it?
not
Choice.
mandatory.
Choice.
Well, you ladies need to take your campaign
Show
back
them
to
the
the
better.
schools. You do, doing a good job.
We did, the lady who supplied the food, that's what she used to do. When we had the family planning grant, she went all around to the schools and did that.
Everything's so different and it's needed today.
Everything's controversial.
Yeah, yeah.
That's what the problem is.
Yep.
I don't want you to teach my child how to do that. They need to know.
I know how to do a breast exam.
Yes.
They
Right,
need
it's
to
like that
know.
whole knowledge base. All right, so that concludes breast specifically. Do we have any other questions about breast before I move on?
Nope, awesome job. Kitty,
All right, cervical cancer.
I wish I could get them up there.
Again, statistics about right, cervical cancer. Cervical cancer incident rates have increased by more than half since the mid-1970s, right? And we all know that that's pretty much because of the Pap test, right? And cervical precancers are diagnosed more often than invasive cancers, right? And that's the goal, right, is to find things early.
I need one of these.
I could use two.
To put in my shirt.
Yeah.
I don't have no breasts.
Most frequently, cervical cancer is diagnosed in younger women, so it's between those ages of 35 and 44. Now, when you look at the next one, you might think, well, how is it that the average age is 50 and most are diagnosed in this? But that's because 20% of cervical cancers are found in women over 65, right? So when you average that all out, the average age is 50. And the mortality rates
Wait a
for
minute,
one
did you say that 65?
Right. So 20% of cervical cancers found are in women over 65.
Why is that? Why is that?
Well, we're gonna talk about risk factors and
Golly
it
gee.
has all to do with length of time, right? So I'll get to that.
Get
I'll answer your
tested,
question.
check down there.
Mortality rates were once the most, so for cervical cancer, the mortality rates were once the most common cause of death for American women. So we've made huge strides when it comes to cervical cancer. So how are we doing locally? Overall, in Cape County, the rate is higher than the state, a little bit. You find that in Cape County in general, right? The numbers are higher than the state, a lot.
Why?
What's the factor? What do y'all think is what's happening here?
Environment, chemicals.
Well,
Yeah.
Yeah, I mean, it's age adjusted.
Older
So
population.
that's not depending the fact that you have an older population.
Oh,
No, because the statistics are usually age adjusted, so it really shouldn't have to do with the fact that you have a higher age, probably like your median age and everything is older, right? It shouldn't really have to do with that. So, I mean, that's a good question, like why it's higher. I think different cancers vary on that,
I
yeah.
have a question, the cervical cancer. When do they stop doing,
Pap tests?
yeah,
Yeah, we'll
could
talk
that,
about that.
oh, okay.
Angela, you don't think it's like environment related
But
because
you do have some Superfund sites down in Cape May, you have, that were cleaned up and all that kind of stuff. I mean,
'Cause-
and I do actually agree with you, I do think a certain
No.
amount of our cancer rates have to do with,
because I was told about someone who died of brain cancer in this particular street in Cape May Courthouse because there was a factory right there on Route 9, and they said that definitely has something to do with it, but no one's looked into it or said anything. But everyone on this particular street had some form of cancer and died. And this person's like a couple years older than me, and they're, getting the treatment and they're better. But when I spoke to her, I was like, oh my God, that got me thinking, like, is that true? Like, can that be possible? And then you just think about different, factories and places in New Jersey where, back in the day, stuff was just being dumped illegally. Now you have all these protocols in place, but back then, before we were born, there were no protocols in place, and you just dump stuff in the ocean, in the ground, in the woods, wherever.
But is that also because you have a lot of people moving out of it, like middle age and seniors moving out of like urban places and down here?
Well, sometimes, yeah, people are coming from other places, right? I mean, they might, what were they exposed to somewhere else? I think we don't know a lot about all that environmental component, because I was just talking to a fireman the other day, and they had some concerns about the suits that they wear to protect them against the fires when they run in, right? So what's in that fire suit so that they won't catch on fire, right? They're sweating in there, their bodies taking, they get wet from, from putting out the fire. So like, what are you
Well, like when you got
experiencing at work, at play, at wherever you are?
when you went
right?
to the dentist and got the X-ray and they put that thing on you and they stepped out of the room to take the picture, but you have this vest on and I'm like, excuse you, like you stepped out of the room. What do I have on me that you just put? You know what I'm saying? So they're taking the picture and they put that thing on you, and now they don't do that. Do they still do that?
Oh, yeah.
They still do that. So what's in that? You know?
Right.
I mean, it's a hot second. But they're taking, if they're taking multiple X-rays,
It's radiation, yeah.
it is see, and they step out of the room.
The thing is lead.
The thing is lead that they put on you at the dentist's office. Great. So
And then what are you exposed to just in general? Like what's in our food supply, like all
Right.
kinds of things.
Water.
We don't necessarily know
Yeah.
what all that stuff, and it takes a long time before they connect those things to cancers, right? So I don't have a great answer for you. I'm speculating, right? Just like we all kind of are. But yeah.
it makes you think, though. It makes
It
you
does.
like, and it does take. And everyone's body's different, so what affects you affects me differently. Like, you know, they talk about mercury, like the fillings in your mouth, and the tuna, and just all these things, but everyone's affected differently.
There's food preservatives, the
Yeah.
pesticides, they,
Yeah.
I mean,
On and on. Wow.
We find a higher challenge for like our Vietnam vets. We know there's a higher prostate rate because Agent Orange has been connected to prostate cancer. Right? So being like, yeah, exactly. Right.
Wow.
So in cervical cancer, again, our numbers in Cape May County, because the county is so predominantly white, although it's changing. It changed a lot from 2010 census to the 2020 census. But our numbers sometimes are still small for our Black, Hispanic, and Asian populations, so they are suppressed. And cervical cancer rates are low on a whole. But again, the mortality rate's a little higher, but I would be cautious of that because it says the rate is unstable, so it's less than 15 cases in a 5-year period, right? So you have to be a little cautious about that. So what does that mean? 23 women were diagnosed with cervical cancer in a 5-year period. 10 women died in that period, but that is almost half of them, and they were all white. Okay. So that's kind of what it was like. But that doesn't mean we shouldn't be diligent about protecting ourselves against cervical cancer. So the big one is the HPV infection, right? Human papillomavirus, which is what you asked about, with the shots and stuff. And that is the big piece. So what is it? It's a virus. It's spread close to close, skin-to-skin contact during sex. It's very common. 43 million HPV infections occurred in 2018. Okay.
Wow.
Yeah. Most infections clear up on their own, 9 out of 10. Okay. And I always loved this one presentation I watched, and the doctor said, you could get HPV the first time you had sex or the 1000th time you had sex. So it's just that common. And when I was looking at things, 80% of women at some point in their lifetime will have HPV, and 90% of men at some point will have an HPV infection in their lifetime.
Okay, you said that's the vaccine.
So that's
What?
just what HPV is.
Oh, HPV, okay.
Yeah.
God.
We'll talk about the vaccine. We're getting there. So a lot of the risk factors really all have to do with that HPV infection, right? So the sexual history, the young ages at pregnancy, the low economic status, like all those kind of things really are connected to the HPV infection, right? And this one, sometimes there's some questions with that. Having a weakened immune system, it's connected really to HIV/AIDS, increases the risk. The reaction has to do with some type of, essentially, in the environment, it makes it more, it increases the risk when you have chlamydia, something in the environment, when I read about that, I read it cheat sheet, that the gestation, has something to do with that. This was, DES was actually on the breast one too. So DES was a drug that they gave women at one time because they thought it decreased risk of miscarriage. So if you received that or if you were in a womb at that time, it can sometimes increase your risk of breast or cervical cancer.
Wow.
But you should know if you had that, like theoretically. What's that like in the?
Well, there
50s and
aren't too many
60s?
women left alive that have had it.
Yeah, and it was like back in the
Yeah,
50s.
I mean, it was in our parents' generation, most of these things.
But they still put it on all the lists of risk factors.
Oh, yeah.
Yeah.
It has everybody, and nobody ever knows what it is, so.
All right, so what can we do about cervical cancer? So the first is to get routine cervical cancer screening. And really the idea of that is a prevention thought process. And so we get our pap test, we find those cells that are a problem early, we remove them, and we're essentially preventing cervical cancer from occurring. And then the second component is, just like what you're saying, is that HPV vaccination, right? So I looked it up for these presentations, and the HPV vaccination was started in, I wrote it down. Was started in 2006. So it's been around 18 years now.
Really?
Yes.
Wow.
So, I know, I feel like I was just learning about that not that long ago.
Yeah,
but
like
yeah.
you just
But
find-
see, they didn't advertise. They-
Right.
Advertisement and educating people,
Right.
I think.
Yeah, I think the problem with the HPV vaccination is that when it first came out,
Mhm.
they were focused on this idea of it being an STD.
Yeah.
Right, and then all
That's
of, everyone's like,
right.
oh, right?
Yeah,
And so that component
Okay.
is what people get stuck on.
Mhm.
Now, when we talk about HPV vaccinations, we talk about it as a cancer prevention piece, right? And
Right.
so we kind of got our hands slapped on that one, right? You know, the idea that we're preventing cancer. So the point of the vaccine is to give it to children who are like 11 or 12 before they ever have sex, so that those antibodies can be processing, and then when they're exposed, they'll do well.
Now, I have a question, what you just said, cause when I first heard about it, I thought too, oh, sexual transit, what I call it, sexually transmitted disease. That's what I thought, but now, as you're saying, it's a preventive for that. And what you just said, that's how they should run it,
Mm-hmm.
but I was confused.
So
I
I mean, your
was.
child could, people will be like, oh, do they have sex more now?
Yeah.
No, they don't.
No.
Like, studies have shown that just because they have the HPV vaccination, like, the sexual, when kids have sex, doesn't start sooner, right? So like, all those things that are disproven, the idea is your child could wait until they get married and still get HPV.
Yeah.
Right? So, you know, that whole component kind of needs to come out of the conversation, and it's really about preventing
Right.
cancer.
Well, when a child is that young, and if they had all their shots, does a mom really, I think it needs to be more out there. Does a mom really take their children to the doctors at 11 and 12
So
if you have
the reason
all
they
your
pick-
shots?
Part of the reason they pick 11 and 12 has to do with the production of the antibodies, right? That's
Right.
the one piece before they have
Got
sex.
you.
But the other piece is that's when you go get your Tdap shots and your 6th grade sock shots that you need. for
Oh,
school.
okay, so they're still, okay, got you. Now it makes sense.
Right, so
Okay,
you have
got
to
you.
get those or refuse those
Mhm.
at that age anyway. So it's a good time to do it at the same time because they're already going for shots.
Is this mandatory or is it optional when they go for the
So
shot?
it's optional, you don't have to get it through
Okay.
school, you know what I mean? The school doesn't require it in any way, shape, or form.
Okay.
But a lot of times,
It's got it.
pediatricians will do that. So I tested my pediatrician because when my kids were at that age, I waited to see if they were gonna introduce it, and that's when they did. So when they were due to get their Tdap shot, they also said, but we also recommend this one, and he said, you can tell, he started on his spiel, and I was like, it's okay, I'm gonna get it, so.
Got it. Okay.
That type of thing.
What are the side effects?
So usually it's just like red arm, maybe arm
Oh,
swells.
so like any booster shot. Mm-hmm.
So you get a normal
It is a series though, so you have to make
Yes.
sure they come back for the rest.
Oh, it's a series?
Yes.
How
How
many?
many shots?
Yeah.
2? Okay.
2. So,
Oh, okay.
But if you don't come back for the second one, you gotta start all over.
It's like the COVID, okay.
What happened?
Well, if you don't come back for the second one, you gotta start over at the
Yeah.
beginning, because they have to be a certain amount of time apart.
Is it, what's the gap? Like a
3
year?
months or something?
I think they tell you 3 months,
Oh,
but
3
I found
months.
that with my daughter, they did it when she was 11, and then we came back and they did it when she was 12.
Right, a year. So there's a
Okay, so
window,
here.
but,
Okay.
but if you
so-
miss it all together, like people say, oh, well, I got one of those years ago. Well, did you get the second one? No. You had to start again.
Yeah.
Right.
Sometimes I've had a lot of questions about how old can you be to still get it and things like that, and they are approving certain age, like up to 45, but it's gonna vary. It's a conversation with the doctor, how much exposure have you had, will there actually be a benefit to the shots if you get them later, and if you're older, it's a 3-dose shot, not a 2-dose shot. That's the biggest difference. But we are already seeing a decrease in some aspects because a lot of HPV also creates genital warts, and they have seen in these younger generations that those numbers have gone down. So the goal is to do that. So, cervical cancer screening. When should you get it? It's become complicated. It used to be like once a year, right? It's not like that anymore. So basically, what we always kind of recommend is, again, you're going to get your annual, which should have a clinical breast exam and a pelvic exam. So you should be going to your GYN once a year anyway, right? When you're there, you can have conversations with the doctor about what your PAP schedule is, when you should have that PAP test, how often you should have that PAP test. But it's gonna vary anywhere up to 5 years, depending on your own personal history. And once you have a PAP test, right, the results are also going to determine when you should have your next PAP test. So those conversations should start with the physician at 21 for PAP test. Now again, I put the 2 differences up here: American Cancer Society, U.S. Prevention Task Force. If you go on there right now, it says they're updating it, so I guess we're gonna get some updates soon. But basically, they both essentially say that 21, 25 age is when PAP tests should start. You can do the PAP test alone, the PAP test with an HPV test. How often is gonna vary on risk, on what your results were, etc. But I don't know about you, Barb, we see it commonly like every 3 years.
Yeah,
Or
if
normal
it's
tests.
perfect,
Yeah.
every 2 years. But if you
Everything's
have
good.
anything wrong with the cells or any HPV, then it's sooner,
It's more
usually
often.
a year, yeah.
Yeah. So, and a lot of times they do co-testing. So PAP test with an HPV test together. That's what I see the most.
We do that all the time.
Now, you asked about age, right? And in all these screenings, even in the breast one, it talked a little bit about stopping screening, like when can we stop? And this is,
When the insurance company said they're not paying.
right?
That's what it is.
Yeah, so sometimes insurance companies say they won't pay for it.
Yeah.
What they find with cervical cancer is if you had repeated PAP tests that have been fine, and you're not having new sexual partners, right, then you should be good, right? Theoretically. I say this when it comes to screening. If you would treat the cancer, then you should think about being screened, right? Because a lot of screening also has to do with the health of the person. So when we get to colorectal, it goes up to 75, and it's a slower growing cancer. So if you were healthy and you would treat it, then you should think about being screened for it, right? So my mom had a friend who was like 80, and when she was in good health and active, and the doctor didn't, she's like, I want a mammogram script, and the doctor didn't want to give her one. She's like, you're 80, you don't need it anymore, right? And she's like, well, if I had breast cancer, early breast cancer, I would treat it. So I want a mammogram script. So that's why I said ask questions, because you'd be surprised what your doctor says, right? So those are the answers to older ages with screening. You know, if you treat it, if you're healthy, right? If you're doing well, then you might wanna be screened for it, if that makes sense.
So the doctor didn't refuse your mother, so they can't refuse you. He has to write a script, or
You did write the script for her, I mean, I think
Uh-huh.
the insurance company paid for it.
Okay.
But they
but
might, but to be honest, a pap test is not that expensive.
Mhm.
Pap test is like, Medicare pays like $20 and HPV is 35, so that's like
But
$55.
I noticed that with doctors, like the older you get, when I was dealing with my mother, she lived to be 90. They do become lax. They tend to be like, well, you're 90 years old. Like what, like it's like almost like do what you want type of thing. And I don't feel like that's a good way to be. You know what I'm saying? It's almost like you could just tell in their demeanor, they're just like, okay, she's 90 years old. What do you want?
Yeah.
Like, you know what I'm saying? Versus someone who was half her age, they would be more aggressive with treatment of different things.
It really depends on their health history.
And their health
Because
history.
70-year-olds can really vary in their health.
Exactly.
They really vary. I mean, I think that's the age where you see a lot. Sometimes when you look at statistical charts, you'll actually see like suddenly, like if you look at the obesity one, for example, it's like low and it gets higher, and then it drops again because the people who are still alive in their 90s are usually, if anything, underweight, right? They're like, right, they're because of the health of those people.
Or if something happened, my mother had a stroke, so that triggered other things that weren't there before. So like once you have a stroke, then you have an issue with your heart. So that, your heart is weakened, so now you get a pacemaker, and it's just so forth and so on. So other things come into play. And
that can become the priority.
And that can become the priority. But then when you ask questions, they just look at you like, well, like, it's almost like, it's weird, because I'm like,
Yeah.
Is this how you treat all the patients? Because it's a little
Yeah.
concerning to me. Because a person, it's almost like ages, it's like instead of being sexist, you're being ageist because a person's old, and the treatment doesn't need to be as aggressive. I feel as though whether you're 5 to 95, 100, the treatment should still be the same. Like, you should treat me no matter what my age is, just because I'm old or if I'm young, what have you. You should give that same level of concern and treatment across the board.
Right, and it's having those open conversations, right? Like sometimes people are afraid to have those conversations, they don't want to. So we know that like after a certain age or a certain component of where your heart is, you might not handle anesthesia as
Right.
well. So like you're a bigger risk to take
That
into
part.
a surgery.
Right,
So
right.
it might be that they
Right.
don't want to do that colonoscopy because they don't want to put you under.
Right.
So they need to say that.
Right.
That's right.
That what you said right there, because what I find out that doctors and nurses they're two different animals. Doctors they're more arrogant with the information they give out, where nurses are a little more compassionate. So doctors will say, they conversate with you in broad terms, and you ask questions to get the information out, but it's almost like you're on a need to know basis. I'll tell you if I feel you need to know. Like you just said, the whole anesthesia part, when you ask the question, and that's just an easy explanation. Well, because based on her age, I don't want to do thus and so because this could happen. And some doctors are good with that. Then other doctors, they look at you like, well, I'm not going to even get into the explanation, and that's where you have the level of care where people are afraid to, have those questions. But I feel as though you need to do it, and it's important. If not, then find another healthcare provider, because you should. Yeah, you definitely need to have those conversations, because it's your life we're talking about.
You have to feel comfortable with your doctor.
Mhm.
They don't want to answer your questions and find another doctor.
Exactly.
Or go to a nurse practitioner.
Yeah, the nurses are
They're a
good.
little bit, they're a little easier to talk to.
I agree with Angela on that, because my mom was in her 80s when she developed breast cancer, and the doctor was like, oh, it's nothing we can do. And because of the health issues, as you said, he was more kinder. And then he was coming to the home, he got to know us,
Right.
and he just said, no, that chemo will kill her much faster. So we understood that, and
Right.
and like you're saying, you got to have that relationship.
Yes.
And don't be afraid. I asked my doctor anything, I was having an issue, and I don't see that. It's not what you see, it's what I feel.
That's right.
And can you just write a script and let me go where I gotta go? Oh, not a problem, he said. So, we have to be persistent, especially
Yeah.
with women.
Yeah.
We have to be more persistent.
You're your own
um,
best advocate.
Yeah,
Exactly.
yeah, absolutely.
And when your children are minors, you're the best advocate.
Absolutely,
Don't rely on just
absolutely.
the teachers, you fight if you know in your heart.
Well, I
You're
don't
the best
know.
advocate.
I was the advocate for my grandson, and doctor said to me, "You're not the parent." And I brought things. I had the parents' permission to take it, but he didn't want to share certain things. So I get that too, you know.
what you
And
tell them?
I would get
The parent wouldn't have been here without me.
right,
So,
but I get
I'm
that.
the overseer.
But I'm learning, you know, you gotta get that, cause it's legal, you gotta get that,
The HIPAA.
paper notarized saying that you can share things with them, I get all that. So you know what, I always tell people, hey, they can't do what I want, I'm outta here.
Or a lot of times you could have like your kids text the doctor's office.
They called them.
Yeah, or call them
Yeah.
to say, yes, they have permission to do.
Mhm. But I just didn't like the response,
Come on, we
so,
have to.
you know, we just have to do what we need to do, legal and in order, and I gotta speak up for them.
Alright, so
Well, that's
we're
what
gonna
I'm
move on
working on.
to the last answer. Any other
Ain't
questions
nothing
on
like
cervical?
grandma. Now I'm going to get some
Alright,
young
colorectal
shot.
cancer. So colorectal cancer is the third
I'm calling them.
most common cancer, except for skin. Women have a 1 in 25 chance of getting colorectal, men are a 1 in 23. Colorectal cancer is the fourth leading cause of cancer death for women, it's the third for men, and when you put them together, it's second. Colorectal cancer incidence rates have decreased since the mid-1980s, right, we'll talk about that. And incidence and mortality has been increasing for populations under 55, so that's why that recommendation has gone down. Here in Cape County, are we surprised? It's higher.
Oh,
right?
boy,
Higher
what's
than the
going on
state.
here?
We have the same issues with suppression,
What's going on here?
and the mortality rate is also higher. So this is just women. I took the men out of this because this was a women's event, right? So 184 women in Cape County were diagnosed with colorectal cancer. 69 deaths occurred, and because I can't get them, the black women, 65 of those 69 deaths were white women. But that's a lot, and so when I looked at the Atlantic County rates too, it's the same thing, it was like almost a third of the people who got colorectal cancer also died of colorectal cancer. And it's a preventative cancer, so we don't wanna see that.
Angela, that's a year result?
Those are 5 years.
That's 5 year, and
5
what,
years.
and why couldn't you get the African American women?
The numbers are too small.
Cause they're not testing?
No, there's just not enough.
Statistically
African
insignificant, there's
American
enough.
women
In Cape
County.
May.
population, yeah.
You're talking about Cape May County?
Yeah.
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 Yeah, it is small. I know Atlantic County is more.
So what I find is in Atlantic County, I can usually get our black numbers, and I can sometimes get Hispanic numbers, but sometimes Asian numbers are still too small. But in Cape May County, you find that it's hard to sometimes get those numbers at all for the minorities in the county, because you're just not diverse enough. But like I said, from 2020 to 2010 to 2020, your pie is growing. So
Oh, yeah.
in 2010, I wanna say it was in the high 90s of white population, and now it's like 80 something
In Cape May
in
County.
Cape May County. So in that 10 years, the population has changed, so,
Is that because more people are getting screened and tested?
no, I mean just,
They're moving down
number of
here.
people that are here,
Oh,
They're
okay.
moving down here.
yeah.
Well, like Whitesboro, the town you're in right now, was predominantly black, and now it is not.
Yeah.
It's
And what-
at 50, almost close to 50%.
Yeah, and I
Half
think
of
the
that.
number that you saw grow the most was like the Asian population is really growing.
Down here, Cape May County. Not Hispanic, because I know
That's pretty
Wildwood.
high,
Well,
yeah.
that one's pretty high too.
Yeah,
They're
Wildwood's
all
got
over.
a lot.
I have a question, when you go to your primary care physician, can you ask them to give you or recommend that you get screened?
Sure.
Oh, yeah.
Okay, maybe it starts with, like you said, us asking.
But the reason your numbers are suppressed don't have to do with the fact that they're not being screened or things like that, they didn't do screening, or that they didn't get cancer, it's just that they're so small. So like they
Okay.
don't, anything under 10 is just suppressed, and
Okay,
anything under 15 is unstable. right? So if you don't have at least 15 people in that 5 years that got the cancer in your community, then they don't report the rates, right? So that's what's happening in King County. It's just the numbers are too small to report those rates. But you can look at them overall, so you can compare it. You can look at New Jersey and like, what does New Jersey look like for the different categories? All right. So colorectal cancer, same thing. Can't change, right? We get older, can't change that. We can't change our race and ethnicity. We can't change our gender, right? Men are more likely. Personal history, that's important to know, right? Because when your family has their first polyp is going to may change when you go get screened, right? My mom's first polyp was at 50. I started my colonoscopy at 40. So things like that. And then risk factors with colorectal, again, the obesity, type 2 diabetes, smoking, like those kind of things. So it comes down to prevention, right? This is one of those cancers we can prevent. So removal, that regular colorectal cancer screening, removal of the polyp before it develops. Polyps take about 10 to 15 years to go from a polyp to a cancer. So that's why there's so much time and the way the screening recommendations are, right? You remove that polyp, it won't turn into cancer. Okay. Maintain, and then the
Why do they grow back?
What?
Why do they grow back? Polyps.
Why do they grow back?
I have them too, I can't tell you. First they said 3 years, then they said 3 years, now I'm up to 5 years, so again.
There are like inherited, like Lynch syndrome, they have a tendency to have lots
Well,
of.
that's a hereditary
But
thing,
those are
that's not
inherited
a-
type things. I mean, I'm not really sure, to be honest.
I mean, when we send people out for them, some of them have none, but many, many people have polyps, I mean, that's not unusual. Yeah.
They say come from.
So, and then the rest of those prevention things.
Excuse me. Is this an old wives' tale or whatever?
Yeah,
Do polyps come from
Hemorrhoids.
hemorrhoids?
that's what the old folks say, don't sit on that concrete. That's what the old
Get a
back
cold,
folks
get a
say.
cold in your butt. I was like, what's a cold in your butt? What is that?
Oh, we gotta get the what's that?
Okay.
Yeah, hemorrhoids are to do with blood vessels, and
Okay.
polyps are not, I'm not sure what they're due to, but they just grow.
Well, we just thank you for answering.
Yeah.
So then the rest of those prevention things all have to do with lifestyle factors, right? Maintaining a healthy body, being physically active, diets, high in fruits and vegetables, low in processed meats, things like that. Right? So again, the key is the screening component. So overall, we recommend people 45 and over for normal average risk start those conversations about colorectal screening. Colonoscopies are the gold standard, right? Because then we can take that polyp out and prevent cancer. However, it's important just to get screened. So something is better than nothing, right? So it's better to do your FOBT kits every year than it is to do nothing. And the important thing is that all those other screenings that are out there, if something comes up, they're followed by a colonoscopy anyway. Now, right here, they list all the different types of screenings that are out there for colorectal. You'll see there's all kinds. That partially, they offer all those partially because in different parts of the country, they don't have necessarily the access to colonoscopies the way we do here in New Jersey. So in New Jersey, we don't have problems with going and getting a colonoscopy if we want one, right? But in some, if we want one, right, that's the key. But in a variety of places, that's sometimes an issue. So that is part of the reason why there's other options. It's also, like you said, like you might not be able to be under anesthesia anymore. So then those virtual ones are good for that, right? Because if you can't handle the anesthesia, that's another way of getting screened. So it has different options. The key is to get screened in some way, shape, or form. And then it's like you talked about, 76 to 85. Talk to your doctor about what's right for you, taking into account of preferences and health and past screening history, right? So can be more complicated go from there? Okay. Again, would you treat it? Colorectal cancer takes about that polyp takes about 10 to 15 years, right? Where are you in your health when you're deciding what to do with that? However, high-risk people, my grandfather had colorectal cancer, so it runs in the family. I started when I was 40, I'm like you, every 5 years, I'm on the 5-year plan, I go back and get that test done every 5 years. So people vary depending on family history, the previous results, etc. Any questions about colorectal? Maybe you already got the tush vet, so we don't need to do too much.
Are those ones that you do in the mail just as valid as, having the,
They're gonna give you indications if there's blood in your stool, and so if there is, then your physician would follow up with,
Oh, is that how it's
with the colonoscopy.
Okay, okay, that's how that works.
Mhm. And just because you find it, doesn't mean you definitely have polyps, it could be something else, a
Could be
fissure,
hemorrhoid. You
or
could get
hemorrhoid,
blood from hemorrhoid.
hemorrhoid.
Or
But it
from
just-
diverticulitis, there's all kinds of things that would keep blood, but
It's a good indication to
Yeah.
know.
we send people to the GI doctor if they have positive, no matter what. Often it's not, they'll do the colonoscopy and often it's not cancer, it's something else.
So if it's, a request, you should just really go ahead and do that test.
No harm, no foul, yeah.
Oh, yeah.
Yep.
Absolutely.
Cause if you don't know, people think the worst, you know what I mean? Or they
Sure.
don't wanna do it because, who wants to mess in your poop, or, you know what I mean?
Well, the
And that's
prep
what
is the
people
worst
say.
part, the test isn't bad at all. The prep is the worst thing, we have to drink all
She's
the.
talking about the kit, not the
Oh, the kit?
Yeah.
Oh, the kit, that's easy, yeah.
It's easy to do, it's not a big deal.
Well, I'm just asking because,
Yeah.
people, they don't wanna do it because of that, they don't wanna, no.
I mean, people are following their dogs and picking up their poop, what's the difference?
Well, you have to ask them how
Well, they clean their babies,
Yeah,
everybody's got food, so.
What's nice about those tests now is you only have to do one stool sample. There used to be a time where you had to do 3, so I mean, it's not that big of, they're really not that big of a deal to do with the stool tests, right? And then that gives you an idea of what's going on. All right, so to wrap it up, we just want to tell you a little bit about our program, our SEED program. We have one for Lane County, Barb has one for Camden County, and we test for breast, cervical, colorectal, and prostate cancer screening for people who are uninsured or underinsured. I looked up your number, there it is.
Oh, yeah. It's in their bags, it's in their
And
bags.
there's cards in the bags, in the blue bag, that will
Okay.
connect you to Barb's program to help people if they need help with these kinds of
Who's
tests.
Barb?
Yes.
Oh, okay.
On the K-May County one.
Oh, okay.
So,
Alright, Barb, when we call you, don't act like you don't know it.
Hey, I answer the phone for everybody.
We talk all
My
the
work
time.
phone doesn't screen call.
Now, I got a question. What if somebody in Cumberland County didn't have insurance? Could they call that
There's a
program?
Well, they have seed, every county in New Jersey
Every
has
county
one.
in New Jersey has one of these programs, so if you call Barb, she'll refer
can
you
tell you
to
which
the other.
one.
Okay, all right.
Cumberland County
I think
is
in
through
Spira. Inspira runs there.
Inspira runs the Cumberland County SEED program.
Never heard it.
So, we do have a challenge for you. If you have insurance and you don't need the SEED program, and you find that card in the blue bag, see if you can find somebody to give it to. Right?
Oh, okay.
Pass that card along to somebody who might need the
Okay.
service.
I can say take them to church, or ask them in church.
Sure.
And then lastly, we have a project that's going with these events is our mammogram deal. So if you get your mammogram between today and this time next year, I have a form, you fill it out, you tell me where you got your mammogram, you send that back to us, and we'll send you a $20 ShopRite gift card.
Okay. So next year, this is a May of 2025.
Do you have a flyer for
I
that?
need one of
I do,
those.
I have-
I gotta
I have
get a
forms.
mammogram.
Okay.
Yeah.
Something I can post on the bulletin board?
Well, it's really supposed to be for this event.
I gotta-
but
Oh, okay.
If you give it to somebody, Angela, if you give it to somebody else
Mhm.
who didn't come to this,
Right,
right, or like they watched our video, right?
right.
Just
Yeah,
write on
still.
the portion
Mhm.
that will come back to me,
Right.
that it came from your church,
Okay.
and then they can send it back to us.
And also, do you have a flyer with the seed program information on it that I can
Yes,
post?
those are in the blue bag.
We put all of our stuff in the blue bag.
All right, so I can post that info, the seed
Oh,
program.
yeah, yeah, yeah,
Got you. That's somebody for.
yeah. One phone number, just me, and we have the Spanish phone number for the Spanish phone.
Oh,
And-
if we just get a mammogram.
Anybody.
Anybody.
So
Oh.
the seed program is separate, that's a program that goes all the time, and that offers those screenings for people who are underinsured and uninsured. What I'm handing you now is just for this talk. If you get a mammogram in the next year and you send this form in, we'll send you $20. It has nothing to do with seed. She said it all at once, but it's separate.
Oh, thank you.
There you go, you're getting your, there you go.
And hey, Barb, bless somebody with the ShopRite card.
All right, so any other questions? Other than that, we're wrapped. Any questions about any other questions?
Thank you.
All right.